Hello, I'm Dr. Maury Markman from City of Hope, and I wanted to complete this conversation that we've had over the last several segments regarding prognostic versus predictive factors in oncology by discussing a couple of items that one might not normally consider. The first is really really making the point that prognostic and predictive factors are just so important in oncology. They've been used for such a long period of time, and in fact, do not need to be complicated, sophisticated, molecularly defined tests. I use as a classic example of this. This has been true for a number of decades now, but really importantly, the use of beta-HCG and alpha-fetoprotein in the management of male germ cell tumors. It has been recognized that a rising HCG, alpha-fetoprotein, is exquisitely sensitive for evidence of progression of a germ cell tumor, not diagnostic of a germ cell tumor. We already know the patient has a germ cell tumor, but once you know that, it's exquisitely sensitive to the evidence that the disease is progressing. So with the disease progressing, that's a prognostic factor of a poor outcome. On the other hand, we also know that chemotherapy is extremely effective in male germ cell tumors, female germ cell tumors as well, but I'm discussing male germ cell tumors here, so that a rising a rising beta-HCG in a patient who in fact has been under surveillance but has not received chemotherapy would not only predict for progression of the cancer, use the word predict, for the progression of the cancer. See that you get into that caught into that. It tells you nothing about the effectiveness of therapy. It just says that cancer is progressing. But in fact, it would predict for a very effective outcome if chemotherapy is started with relatively small volume disease because of the exquisite sensitivity of this malignancy to chemotherapy. So here, the beta-HCG is an indication of progression of the cancer, poor outcome if you don't do something about it, but also evidence that if you start the chemotherapy, available chemotherapy, the outcome could be very positive. It's one point to be made about prognostic, predictive for something that's actually very simple test in the laboratory. And final point I want to make is to emphasize that this is an evolving area as we develop new therapeutics. So let's take, for an example, a particular strategy that has been used in the cancer types that I'm most familiar with, been involved in my career, the management of ovarian cancer. Second look laparotomies or second look laparoscopies were widely used a number of decades ago to assess the status of the disease following the completion of chemotherapy. It was used before the days of CAT scans, et cetera. But even in that era, with the availability of scans, the hope had been that if one were to do a second look laparotomy or second look laparoscopy, you could find a patient population that was cured of the disease. So it would be a very meaningful outcome. Yes, it's a surgery, but you can say this patient is cured. We learned that's simply not true, meaning that even a negative second look laparotomy or second look laparoscopy, the disease could certainly come back. So that technique, a diagnostic technique, was very appropriately discarded. But what if pharmaceutical industry, working with academic research, etc., developed a very effective localized strategy as a follow-up, you can call it consolidation, after response to chemotherapy. But the only population where it made sense in, based on trials, were the patients who, when you did a second look surgery and looked, you found documented microscopic disease. Best use of the drug is in presence of only microscopic disease, but you wouldn't want to use it, or you couldn't justify it in a patient who might be cured at that point. But if you did that second surgery and found a patient population, found a group of patients with residual microscopic disease, only could be found by surgery, for example, that could lead to the use of a therapy that in fact could become curative for that patient. But you'd need the test to be able to find the population. Now, obviously, I'm going a number of steps down to be able to say this is a valuable test. You'd have to do all this. My point is that a particular diagnostic strategy, a particular test that we are not using today because it doesn't predict for a therapy that might help a patient, could in the future, that same or a similar test become valuable when we developed, or if it happened that a particular therapy was developed that was meaningful for a patient when defined by that diagnostic. Open for conversation. I'm just really saying this is a very interesting topic that I look forward to seeing new developments in the future. And I thank you for your attention.